Thank you so much for joining us today for the webinar Minimally Invasive Aesthetics in Everyday Practice. We would like to thank Dr. Jure Poglajen for being with us today and our sponsor for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by the doctor at the end of the presentation. Without any further delay, please help me welcome the expert himself, Jure Poglajen.
Hi, good evening Europe and Africa, very good morning to Asia, and good day to both Americas. My name is Jure Poglajen, and this is Slovenia calling. Today, summer is back in Slovenia. I guess we had lovely 22 degrees Celsius, and I hope you enjoyed your day as well, as much as we did. So let me first introduce myself. I'm coming from Slovenia, which is a very small middle European country, member of the European Union. We are only 2 million, and our capital is Ljubljana, where I was born, raised, and educated. The medical faculty of Ljubljana for the 6-year program for dental medicine. Ljubljana is a lovely city with a lovely city center. This is the square close to the Shoemaker's Bridge, as you can tell by with the fact that there's many shoes there. So then I moved back to our hometown, Brežice, which is the last Slovenian town if you are going to Croatia. It's a small picturesque town with a lovely castle where you can find Knight's Hall, and this Knight Hall you can also find the replica, of course, in our lobby at our dental clinic. Our dental clinic is family-based. We have 3 doctors and 2 nurses, and we are performing all the basic dental procedures, but specializing in dental lasers, both hard tissue and soft tissue lasers. So, dear colleagues, ladies and gentlemen, what are our basic demands for our everyday job? We have to have some kind of standards that we are aiming to. First of all, because we have many patients, majority of us, our work needs to be as easy as possible, so we don't burn out. So in that sense, we have to treat the majority of cases with success. So successfully. So we have to. Our goal is to refer as minimal as possible. So the majority of the cases stays in our dental clinics. Of course, we have to spend as little time as possible, but still be efficient, and we have to do it in a quality way. My favorite is we have to have low biological cost, which means preserving the natural tissues. In plain language, I would say we have to add, not to take. Of course, since the mouth and the face is an aesthetic area, all our solutions have to be aesthetical as well. At the end, we need to have satisfied patients and satisfied us also in the financial results. So let me, dear colleagues, tell you what would the structure of this webinar be. In the first part, I will be presenting the material, or shall I say the tools that we use. In the second part, I'll show you 4 of my clinical cases, and in the third, you have the chance to raise some questions, and I will try to answer them. So since I'm a person of more pictures, videos, and less words, I'm going to show you a lot of videos and a lot of photos. In this webinar, we're going to present this material, the tools, as I said before. So let's start with this controversial subject. Are we aware of the fact that iatrogenically we're doing from 64 to 69% damage to the neighboring tooth when we're performing the preparation of the second class? I think this information is astonishing. So if we are aware of that, and this is scientifically proven, so we have to avoid it if we can. So a long-term result in the neighboring tooth is caries lesion, of course, and we need to avoid it whenever we can. Since we all undertook the Hippocratic Oath, and one of the major points is primum non nocere, which means first, do not harm, we have to prevent this. So I'm offering you the solution for a safe class 2 preparation, and that would be fender wedge. So what is a fender wedge? Fender wedge is actually a combination of steel plate and a plastic wedge. It has two roles. The first one is to protect the neighboring tooth while we are doing the preparation of the class 2, and it's also a space maker. So later we can insert the metric easily. And it's for one use only, and it comes in 4 sizes. It's very important that we choose the right size. So here we can also see that it also protects the gingiva, which is very, very, very important. And this is how it is inserted between our preparation and the neighboring tooth. And after it is inserted, we can safely, with no worries, do the preparation of the class 2. Here I'm going to show you the video where we are going to do the preparation of the second premolar, and we are shielding the first molar. Now we have the protection, and now we have the space for the matrix later. And here we are doing the preparation with our erbium chromium YSGG laser. There's no anesthetic, and here are the parameters used in this case. So, dear colleagues, all the videos are quite long because I wanted to show you all of that. I didn't want to trim them. So, from time to time, I'll take the liberty to shorten the video when we're going to see everything what is supposed to be seen. So here we're doing safely the preparation. Of course, we have to be especially careful with the laser and the metal plate. And we are moving to the next slide. So after we have space and non-damaged neighbors, so after fender wedge, we need to insert the matrix, and the matrix would be called fender mate. So it is a metric for a class 2 preparation, of course, and it will only solve 50% of the cases, so not all of them. It again is a combination of a wedge and pre-curved matrix. And backside has an angulated wing, which enables a tight fitting of the matrix cervically, which is the most important. So there are no overhangs. It is also a matrix for natural contact because it's pre-curved. And we can insert it both buccally and lingually. And it comes in 2 sizes. And later, after we fill up our cavity, the cervical ceiling remains intact. So only lingual and buccal surfaces are actually the one that we needed to do some more reshaping. And as I said before, it comes in 2 sizes. It comes in 2 angulations, actually left and right. Depends what we need at our case. And here you can see there are 2 buttons where the metal plate is attached to the wedge. These buttons can be this metal plate can be there also detached, so we can reshape it accordingly to our cavity. And here we're going to see the video how we are inserting the fender mate where the fender wedge was previously used. Sometimes we have to use some force, but still at the end you'll see we have a tight contact, and we have the matrix very tight cervically, which is the most important, so there are no overhangs. And of course, since we are talking about aesthetics, the anterior regions is the most important, and there we do, of course, a lot of preparations. And here we are presenting proxipal, which is transparent matrix. Of course, it has a special curvature with linear escalation, which I'm going to explain a little bit later. It ensures us a perfect contact, and also the cervical part, which is vertical, stays in the sulcus, and it somehow anchors our matrix, and of course prevents bleeding and prevents blood and moisture to enter into our future restoration. Of course, dear colleagues, we all wish to restore a natural anatomy, and it's not all the same if we are restoring a lower or we are restoring an upper incisor. anatomy is different. And we all used to use this 2D matrix, but with 2D matrix, you cannot be as successful as with the 3D matrix that we are presenting here. So in this slide, we can see that proximal, the indications are class 2, class 4, I'm sorry, large class 3, and closure of diastema, which is actually my favorite. As I said before, the curvature of the matrix escalates linearly along its total length. The matrix on the first side looks very simple, but it's far from that. So here, pay attention to these two arrows. So the first one ensures us of perfect contact, and the second one ensures us of intercellular stability. And as I said before, prevents moisture and blood to interfere, and also anchors our matrix, so we don't have to hold it. So the linear escalation. And as I said, by pulling the matrix back and forth, we find a suitable position. As I said before, it's not the same if we're doing the upper or the lower incisor restoration. And again, we have sulcular fixation, and this one is ensuring also as a proper contact. We can place the matrix first on one side or one side only, but we can also have the double sulcular fixation. And you probably wonder who invented this. And I have a special privilege that that I can present to Dr. Mats Norman from Sweden. He is a proximal inventor, and he kindly allowed me to show you 4 of his cases. So for the first one, he made the diastema closure with proximal, of course. And here we have large class 4 buildup, very nicely done. And double class 3, he uses 2 matrices at once. And again, one of his diastema closure, I think it's done very nicely. So thank you, Mats, for that. And now we are moving to the next tool, as I like to say. It's dry dam. In order to be successful and to control the moisture, we have to use the rubber dam. So I'm presenting this kind of rubber dam, which is has a very easy application and fits like a mask. We are actually anchoring it around the patient's ears, so that we don't need any facial arch or anything else. I'm using it mostly for safe amalgam removal, for of course for the composite and glasionomer fillings, for endodontics whenever possible, and also for bleaching. So, dear colleagues, in our dental clinics, we already have all the tools, and what we actually need is the disposable rubber dam, which is in this case dry dam, nothing else. We have the hole maker, we have the forceps, we have the scissors, we have some kind of wedges or clamps. So in this video, I'm going to show you how we were placing the dry dam to our patient. We're going to isolate 2 teeth, 1 premolar and 1 molar. We're going to anchor it, stabilize it with a clamp, with a metal clamp. And at the end, we're going to anchor that rubber dam. We're going to use the patient's ears actually to do that, which is very handy. On the next video, we're going to show you how one can also insert a matrix after we install the rubber dam as well, because the tunnel preparation was already done here on number 5. So now we need the matrix to make a filling. So it's done. Then we are moving to the video where we're using dry dam. In the case of safe amalgam removal, I don't know how it is in your countries, but in Slovenia and all the other neighboring countries, the request for safe amalgam removal is growing fast. So there are there are more and more patients coming to our dental clinic, asking and demanding their amalgam fillings to be safely removed. In this manner, we use, of course, special burrs, we use oxygen, we use dry dam, and of course the suction. So this is how it's done. We're doing this on a daily basis now. And then, of course, our main thing, I would say that we are special, is the laser, or are the lasers. We're using two different lasers: soft tissue diode and erbium chromium YSGG. And this is my lovely assistant Nina presenting both of them. So, of course, we have to ask ourselves, what are the laser usage advantages? I would say not just because it's a modern dentistry, but in most of the cases, it's also painless. But we should not promise to our patients that the procedure would be completely painless. Sometimes it's not, but we can say it would be less painful. That's for sure. We also always have a sterile area, and it's also more hygienic because we're actually not touching teeth or our preparation. There is a slogan we use: no shot, no pain, and no drill. And every time there's a side effect, which is a good side effect, is biostimulation of our natural tissues. Also, we can do pain modulation, and we can do relatively safe bleaching. And then we come to our second part, which are the four clinical cases I'm going to show you. I'm going to show you the diastema closure, the class 4 buildup, post-trauma reconstruction, and class 2 restoration. So the colleagues, let's see the first case, which is a diastema closure. This young lady, her name is Maya. She's 23 years old, and she was very unhappy. She's a student, and she was very happy about her diastema, about, as she says, the space between her teeth, and she wanted badly to be repaired, or to be aesthetically enhanced. And of course, she didn't want any veneers, and she didn't want any orthodontic treatment neither. So I proposed that we should close her diastema with composite. We're going to use this kind of material. And first, we have to carefully choose the correct shade. Well, my experience generally telling me that I always, whenever I cannot decide between the shades, I always decide for the darker one, because it's more easy to hide the darker composite than the lighter one in the restoration. And then we're using our erbium chromium YSGG laser. Then, of course, we do the etching. And we use the 1-coat 7 bonding system. We are soaking it richly to our enamel. And after that, of course, we're going to use our proxipal matrix. As I mentioned before, we're moving back and forth to find the correct contact, or the correct curvature that we want. Of course, we have to pay attention to the symmetry. We have to pay attention to the medial line, or we can use two matrices at once, as Matt did. Then we are placing composites first on the tooth 1-1. Of course, we're starting with the dentin shades, and then we're going to use the enamel shades. We're using different instruments. I like to use brushes as well, so we can smoothen the lines between the margins between two different shades and the natural tissue. So you can see we anchored the proximal matrix into the sulcus only on one side here because we're doing the diastema closure. And the polymerization. Then we're moving to the next video where we're going to put enamel composite, and then we're going to place the matrix on 2-1. It's actually the same procedure. And we're going to put build a composite on 2-1, first the dentin shades, then the enamel shades. Always I'm trying to build up with a little bit of excess, so after polishing we have the correct size, so we're not we don't end up with the tooth being too small. And of course, as I said before, I'm using the brushes and polymerization. At the end, we use some diamonds. I'm sorry, we have to go back. We use some diamonds for polishing, and Profi paste. I used two different gradations of Profi paste, the blue and the red one. So I really get smooth surface and later no discoloration. And we're using the Profi cups as well, which are ideal to use together. And then we had the situation before, so we have not so large the diastema, but the diastema that really bothered our patients, our Maya. And then after that, that's the final result with this composite. And now, dear colleagues, we're moving to our second clinical case, which is the class 4 buildup. This is Maria. She's 46 years old. She's a professor at school. She has a central incisor composite buildup. She was very unhappy about that because she broke her tooth, and of course she had to lecture every day. She needs to be fit for that also aesthetically. So she didn't want any veneers. She didn't want any preparation. She wanted to preserve her own natural tissues. So we proposed the composite buildup. So now you can see also with the open mouth and the palatal view. First, of course, we have to choose the correct shade. And then we are doing the small surface modification with erbium chromium YSGG laser, which will actually enhance the adhesion. And later on, you're going to see, after that, we're going to etch with acid, but only with selective etching. We are not going to etch the dentin, just with the laser. And these are the parameters we used. And etching with acid. And then we have one coat bonding. We wait, we air dry, and then we polymerize, of course. And then we are placing a proximal matrix. This time we're going to use double circular fixation. So this is quite large class 4. Class 4. So in both sulcuses, mesial and distally, we are anchoring our proximal matrix and try to establish a natural contact. Then we are already building up with the dentin shades. You see the double sulcular fixation using the brushes, of course. And polymerization. A little bit more of composite. Of course, we have to be careful. We should not exceed 2 millimeters of our composite layer. I prefer just actually 1 millimeter, not more. So we are reducing the shrinkage. We all know that. And again, finishing with dentin and enamel shades. We're going to use some more of enamel later to finish it up. Though I must say that the patients do like this because everything is done in one session only, so they don't have to wait for the veneer. And the longevity of these restorations is quite acceptable. So if something really breaks, we can always add the material. And here we have the final result. As we remember before, it was something like that. And after the final result, I think it's quite acceptable with the open mouth and the palatal view. And this would lead us to our third clinical case, which is post-trauma reconstruction. This is Matthias. He is 34 years old, and his story was like that. He and his family went to the seaside to Croatia, and he had an accident in the nightclub. He fell quite heavily, and he broke quite a few of his teeth. And the next day, he called me, and he came to my dental clinic. So now you can see the lateral incisor is totally broken, but it was already endodontically treated before. The central incisor is partially broken, so we'll reconstruct that as well. But you can see here he has a fiber reinforced bridge anchoring on number 3 and number 5, making number 4 pontic. This also actually broke because we have the complete number 3 canine fracture, as you can see here. Total fracture of the canine and quite deep in on the buccal side, and the number 3 is still vital, of course, as you can see here. So first, we decided to reconstruct the central incisor. We use the erbium chromium YSGG laser to prepare the surface and to enhance our adhesion later. Then we are using the matrix to restore the central incisor. So we are anchoring it into the mesial sulcus and also the distal one, and try to find the proper shape for a nice reconstruction. You see, I'm only holding the matrix on the palatal aspect, so we have some kind of a base for our filling. Then, of course, we're doing the composite buildup using the spatula, and later we're going to use brushes. And then we are shaping and polishing with first the diamond, and then we're going to use some pastes, and we're going to finish this central incisor. Of course, we did the endodontics on the canine. We did a vital extirpation and root canal filling. hoping that this tooth survives, because it's crucial for the future restoration. And of course, we placed the post to the lateral incisor, since it was already endodontically successfully treated, and we put the post and composite build up again with Proxipal. So this will be the temporary solution for the first session. Of course, this is not the final result. We are hoping that the canine survives, and if it does, we're going to put a post there and make another ponting with number 4, number 5, and number 2. And our final clinical case is a class 2 restoration. So this is Matej. He's a student. He's pretty much aware that his amalgam fillings are not good for him, so he wants them replaced. This is a tooth 1-6, the first upper molar. You see, we are anchoring the dry dam behind his ears. We are putting, of course, the fender wedge to protect premolar while we're going to safely remove the amalgam filling. We already removed the filling, and now we are removing the caries which it was present beneath the filling with our erbium chromium YSGG laser. So the situation is like that. Okay. After that, we put fender mate in place. This is let me remind you, this is the metric that follows fender wedge, the protector. Of course, we put some glasionomer liner as well, which I do normally under every composite filling. Then we put one coat 7 adhesive. Then we wait, we air dry, we polymerize. And of course, we are putting composite in layers. Again, we try to pay attention. We pay attention that we are not exceeding 2 millimeters of our composite in one layer. We use the dentin and the enamel shades, even though this is posterior region anesthetics are not as important as are in anterior. So, and then we remove the matrix and the rubber dam. Sometimes the wedge is detached from the metal plate, but then we use the explorer. We anchor the matrix and remove it. Then we remove the clamp and our dry dam. Of course, we have to do the polishing of the surface. In majority of the cases, we use the Diatec polishers. Sometimes with water, sometimes without water, so we can get a really smooth, nice surface. Of course, there are no overhangs because we used fender mate. And then at the end, I like to use Profi paste with the Profi cup. And as I mentioned before, I'm using 2 different ones. First the blue one, and then the pink one. And this is the final result of our safe amalgam removal and composite filling with Brilliant. So, dear colleagues, let me invite you to our next webinar, which is going to be holding the December 1st, 2016. It's going to be easy, predictable, everyday endodontics. And we're going to especially focusing on irrigation and calcium hydroxide medications. So please join us. So this is my team again and my photographer, Jure, he bears the same name as I do, Jure Wurek. So, ladies and gentlemen, thank you very much for your attention. Now we came to the end of our presentation, and of course, if you have any questions, I'll try to answer them. So let's see. Wael Al-Hassani Al-Jaziri is asking me, you don't use chord retractor with the matrix for diastema closure? No, I actually never tried that. There was no need for that. But thank you for the tip. Maybe I'll do. Where is the rubber dam? The rubber dam I showed you is called the dry dam. Then Nuna is asking me, aren't you worried with the saliva contaminating the restoration, thus decreasing its success? Yes, I do worry, and I try to always when I can, I try to use the rubber dam, but not always. As my colleague from Croatia tends to say, rubber dam is not a religion; is an option that sometimes can improve your work, but sometimes really cannot, and it's not necessary all the time. Then Olga is asking me, what do you use on your brush? Well, I'm using the same adhesive as I'm using for as I used before. So sometimes, of course, we have to be careful not to dilute our composite too much because it can lose the physical properties. So I'm using the answer is I'm using the adhesive. Viola Kassan is asking me how much the thickness of the matrix proximal. Wow, this is a technical question. I must admit I haven't measured that, so I think the company director will come back to you with this information. Olga, what laser do you recommend? Laser. Well, of course, I'm partial here. I use Biolace, I use I plus, YSGG, and I use Epic as a diode. I do have experience with those lasers only. That doesn't mean that the other lasers are bad. I think they are all good. It all actually it's more depends on that how you use it, and if you're used to that, then it works. So Mats already answered. It's 7 microns. Thank you, Mats. That's an information from me as well. While is asking me, do you use a wooden wedge to fit the matrix to create the contact point? No, I rarely use wooden wedges at all. So no, I don't use that. Well, to create a contact point, where do you mean that in the diastema or class 2? That's also a question. Diastema. Okay, no, never, because there is no need. But I think I would propose that technique of the inventor. Use 2 matrices, 2 proxy pulse, and then you can see the contact from the very beginning where it's going to be. So are there any more questions? You're welcome, Well. Do you use Olga caries? If I use caries detector, no. Maybe on the faculty you use that, but after that, no way. Rosa, where were you, Rosa? Well, I haven't seen you, Rosa, before, so I'm not ignoring you. So I'm still waiting for the questions. Please do ask. Try to answer that. Norman is Mats is answering. You work 550 microns is standard for most matrices, but 70 is necessary for achieving the stability of the matrix. Yes, I do agree. I think it's that they're a little bit thicker, but they're more stable for that. Any more questions? Well, if not, I will I just need to thank you for attending. Oh, Rosa, I'm sorry, Rosa. When you did the etching, you didn't protect the adjacent to, so you are doing unnecessary etching. Do you consider to protect with the matrix? I don't recall that we did not protect it, but we are etching with the gel, which is very stable, so it doesn't go to the neighboring tooth anyway. The anterior case. The anterior case has to be etched on both sides. You mean diastema? Oh, the lateral. The lateral case, we did not have the lateral incisor. We have large class 4 at Maria's case. Maybe that's what you mean, but the lateral, no. But anyway, thank you very much for attending this webinar. Let me remind you, the 1st of December, we have the endodontic one. So I hope to see you there, or you see me there. Bye.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.